Matthew Holt, another THCB Spotlight. I'm standing next to Mike McSherry. He's the CEO of Xealth. Spelled confusingly with an X, not a Z.
Missing variable.
Yeah. That's what it is. The X. All right. You got the X there, Zoya? Right, that's it. All right. So Mike, first things first, you came to this world from like the techie world where you built a keyboard that ended up on phones. Just before we get to Xealth, tell me a bit about that background and your techie background in that.
Sure. I co-founded and was CEO of Swipe, a touchscreen keyboard that was put on 2 billion Android phones. And instead of like tapping, you sort of drew the word and it would auto-predict. I was put it on every single Android device globally, and now iOS 13 pushed out a Swipe-like version. So
they stole your IP.
This is ubiquitous on all touchscreen phones.
Very good. Yes,
and before that, I co-founded Boost Mobile. So,
of course.
I've
forgotten about that. So all right. So you realise that technology is a good place where you can get to 1,000 screens, 1 million screens, billion screens easily, change behaviour quickly, get people products they like, and then you decided to come to healthcare. Why would you do that?
I was on the board of a local system up in Seattle that merged with Providence, and we'd sold Swipe to Nuance, and I was leaving the parent, Nuance, and CEO of Providence invited me to come think about startups in healthcare, and I'm like, well, I'm on a board. They solve big picture problems. Startups solve day to day, and he invited my Swipe team and I in as entrepreneurs in residence, and they said, come up with a clever idea and we'll bankroll it and spin it out. So we invented Swipe after 70 plus different ideas, and we've spun it out, licensing it to other hospital systems.
You mean Xealth?
Xealth,
Sorry,
yes.
You're in Xealth. Anyway, so that's with Aaron Martin, his group of Providence, right?
Yep.
Okay. So so let's take a little bit. So what is Xealth? What does it do? What's the problem it's fixing?
So there's a range of digital health services that are now beneficial in patient care. And we easily let clinicians recommend these to patients and engage the patient into an easy form of adopting, authenticating to these digital health services, and then round trip to show the clinicians the patient engagement against that. And the range of digital health services, articles, videos, apps, behavioral health, maternity, weight, diabetes management, devices, so we're tracking glucometers, CPAP devices, EKGs, and we're also prescribing e-commerce products, meal delivery, Lyft rides. So the range of digital health services that could be facilitated to let a clinician easily refer a patient and then track the engagement levels is valuable and necessary.
All right, so now I'm a doctor. I'm in my system. I've got I think you originally told me that Providence had 4 different versions of Epic, or is that right?
Or more.
A number, and there's lots of complexity. And you've built something that sits inside Epic and also other systems, right, as well?
Yes.
Right? And now I'm a doctor, I can be in my typical workflow, and what happens next?
So the clinician would...
Are you going to show me? It's pretty easy.
Sure.
All right, show me.
So this represents an Epic or Cerner clinician UI. Matthew, why are you in today? Have you been doing your exercise? Still taking the pills? Okay, here's what I recommend. And within digital care, embedded in the care navigation of this system, is a recommendation algorithm of appropriate digital assets. Now these get triggered against the clinicals, the lab results, the age, gender, diagnoses, anything that would serve as a filtering criteria for the relevancy of this and the appropriateness of this against the patient. Also, we can marry up to payer eligibility. So Weight Watchers and Omada are not only relevant against the BMI, patient would not be pregnant, anorexic, or bulimic, you'd never recommend or prescribe one of those. But then it's also married up to the payer eligibility. So we're doing prior auth on digital health assets into the clinical workflow. And so for a clinician to order one of these, they simply need to hit order, and the app, program, device will be delivered to the patient. And I'll show some of that user experience. We can, I'll prescribe an article, a video, and an app program. This is all searchable as well, should the patient be asking questions about other things. Other things that we've launched are maternity product recommendations, so e-com against the questions that a maternity or pregnant patient might have. If someone broke their leg, this little wheelie cart scooter could be beneficial for the patient, and we'll say grabber. And so that's the extent of a clinician prescribing something.
So before we leave that, there was a little bit of controversy when you were first announced that this was somehow a Trojan horse for getting more products from Amazon. Just clear that can go to anywhere. No, e-commerce can go to anywhere.
Yeah, just like you can't force a patient to only pick up meds at Walgreens, there's consumer choice. There will inevitably be consumer choice on where they would prefer to have their e-com storefront. And obviously there's a big battle going on that retailing front on that level. But we integrate what our hospital customers deem important for their patient care. So they're choosing the vendors and the different services lined up against what they believe the best care needs for that patient population is. So then the patient experience, they would get an email or an SMS saying, hey, you need to log into your patient portal. So this would represent the stock patient portal.
This is a typical My Health portal.
Yeah. This is representative.
One of the dozens the average patient has.
My chart, my UPMC, etc.
Right.
The clinician clicks into there, and they would see the videos that have been prescribed, the products that have been prescribed, and then they can click in, watch, download, answer, buy. So they click into grab that cart, and here's the Amazon product purchasing. So we've prescribed things to the patient, they've watched it, they've downloaded it, they've bought it. And then back in the clinical interface, we have an order view and a monitor view. So we integrate all third-party apps that we've prescribed, and then we can see whether the patient had engaged in that Weight Watchers app, whether they bought those products. Here's a third-party view of the patient's engagement against a behavioral health screening program.
Okay.
So we bring all this data back into the clinical workflow, and importantly trigger alerts for non-compliance or device data falling outside of ranges, or completion or non-completion of said activities. So we can prescribe, engage, monitor, and alert for risk interventions when necessary. And we've integrated over 40 different vendors across our dozen large provider systems, and we believe that we are going to sit in benchmarking of knowing the digital health effectiveness across all these different digital therapeutics and digital interventions.
So you're positioning Xealth as essentially being an integral part of those big EMR systems or those big EMR vendors' workflow tools. A couple of questions for that. First is, what's the clinician reaction to this been? A lot of people say, there's too much in the EMR already, it's going to be another workflow I can't deal with anymore. So how are you dealing with that problem, or has that not been the reaction you've had from the clinicians?
So it somewhat depends across the service line.
Yeah.
Primary care, don't give me yet another thing. But by the same token, when an overweight patient comes in, I'm like, 10-minute visit, I don't know, join a gym, come back and see me in 6 months.
Yeah.
So this is an offload into a covered benefit that would be eligible for the patient. Against specialty service lines, they often have this one vendor that they know solves this immediate acute need for that system, but ITIS is a bottleneck for getting it integrated. So we unlock that. We're a power strip. You plug Xealth in, and then you plug all digital vendors on top of that framework. I showed a manual effort. A clinician clicks, doctor, nurse, MA, rule-based, trigger pop-up alerts on conditional matching, all of that. We are also doing algorithmic determination and on an automation basis, pre-visit, post-discharge, sending out material. So patient ed before surgical procedure, the care pathway.
Gets it automatically anyway.
Yeah. And so, this time next year, we estimate that we're going to be intercepting 150 million patient visits across all of our hospital customers. And algorithmically, what do you want to engage that patient with? Pre-surgery, pre-visit type, and then on a discharge basis. And that discharge includes products, it includes rehab exercise videos, readmit, educational material, because and what this also allows the hospital system to do is stair-step into risk-based arrangements. So before, they were only episodic reactive care. Now they're knowing the longitudinal view of the patient and their connected life against devices and apps and third-party services. So the engagement numbers that we're driving, as well as the remote patient monitoring, are allowing them to play a more substantive role in how the risk arrangements are shaping up.
So, related but different question. I see you take your question running down here, which reminds me was running Cerner's integration platform a while back. So the two biggest EMRs, Cerner's and the Epics, not known particularly well for playing well with others. They now both have app stores, but they've had their issues. So you may know I did a study on APIs and access to them, and not everyone's thrilled about that. They're getting better, clearly.
Yeah.
You're kind of going another route. You're kind of building an API platform that's buried inside it. What's the reaction you've had from Wisconsin and Kansas City about what you've been doing?
They've been supported. We're collecting an aggregation of third-party complexity that they don't deem important or relevant to them. Much like SureScripts has aggregated the complexity of med prescribing, we're doing the same for digital health. We have a clinical decision support tool. It's a recommendation algorithm, and typically the EMRs have not done much in that capacity. We customize the patient experience against the branding, the patient portal, the doctor configuration for that hospital system, and then the aggregate analytics against these third-party sources and these API integrations. So, we think it's a complement to what AppWorks and Cerner Code are developing, and we're partners against both programs. And so we continue to see us proliferating in a collaborative fashion with those efforts.
All right. So let's do a quick update on where the company is. You started off in, I think, UPMC in Providence and a couple other places.
Yep.
How many provider systems are you in now? How many systems are the EMR systems you've integrated with?
We've integrated against Epic and Cerner, live against 6 systems, signed another 7 contracts, negotiating another 10. So we spun out two years ago, and against that platform development and scale and case studies. And so now we're seeing repeated use cases, and I want that too, and how do I get that?
And within those systems, how many clinicians typically start using it, and how does it spread?
I mean, sometimes they start on a pilot basis, sometimes they go against a service line, sometimes they just go straight to automation, so no clinicians touching anything.
Right.
So, at Prov and UPMC, we have upwards of 1,000 clinicians prescribing different activities across different service lines. But then we go to automation use cases, or 100xing the volumes without any clinician intervention. But you can't always automate. If you're going to prescribe a behavioral health tool to the patient or an oncology tool, you probably want to have a communication with that patient beforehand. So you can't automate everything, but in the high volume, burdensome workflows that nurses and MAs are buried under in their typical day-to-day workflows, if you can automate those processes, it's beneficial for everyone.
That's very good. All right, so just a quick update then on Xealth, the company. You raised an initial round from those big providers.
Yep.
Done another round since. Remind me what it was, how much, who kicked in, and where you are on sort of fundraising side.
Sure. We just closed in June, so $14 million, and one lead VC, DFJ, and then 10 strategics. So Prov, UPMC, Cleveland Clinic, Memorial Care, Atrium, Freighter, and then Novartis, Philips, ResMed, and McKesson. So all strategics, all propagating what we hope is the de facto digital health platform in the provider ecosystem.
And you're at how many employees now?
55.
55, growing from, where were you when you started? When you left, when Aaron Martin kicked you out, how many, what were you at that point?
7.
Okay, so modest growth. but you adding 50 in a couple of years, not much money.
Yeah.
That's good enough.
No, but signing great deals and great customers and the multitude of use cases are.
I'm teasing about when you get this to be. So going back to where you were, right? Where we started on 1 billion screens or 2 billion screens, or whatever it is. This has a lot of impact. There's a lot of places to go, not only in the US but also global. Push the boat out. What would you consider a really big success for Xealth? The numbers in terms of users, volume, patients, how you want to define it?
I want ubiquity across EMRs for prescribing and monitoring digital health, and that monitoring creates aggregate data on the effectiveness of digital health. We believe that we can sit in the benchmarking of knowing digital health effectiveness across the U.S. provider landscape. Ultimately, I've got investors and partners that would bridge us internationally, but we need to conquer the U.S. first. We need to penetrate the U.S.
Conquering penetration. Well, I think it's the Canadians who could be conquering that.
All right. It's American imperialism.
Reverse. All right. I'm with Mike McSherry. He's the CEO of Xealth. Mike, thanks for your time.
Thank you.